Assalamu alaikum. I'm Dr. Ambreen and I'm the assistant professor at University of South Asia. I'm delightful to be here on the platform of University of South Asia, where we are going to continue with a course of pharmacology and therapeutics too. And in today's lecture, we are going to study about anti-tuberculosis drugs. So let me tell you the learning objective of today's lecture, then we will move towards details of tuberculosis. After the end of this lecture, you would be able to understand that what is tuberculosis and what are the drugs that can be possibly used in tuberculosis and how they are going to play their role in the treatment of tuberculosis. So you would be better explain that why we are going to use different drugs in combination than we are going to use to treat the tuberculosis. So moving towards the details of this lecture, let's have a view of the last lecture that what we have studied in the previous lecture. Previously, we have studied about aminoglycosides and we have also studied about macrolides. Both are antibiotics, but both of them are going to inhibit the bacterial protein synthesis, while the aminoglycosides inhibit the bacterial protein synthesis and acts as bactericidal, while the other macrolides also inhibit the bacterial protein synthesis, but they do act like bacteriostatic. We have studied in detail the bactericidal drugs are those drugs that are going to kill the bacteria, while the bacteriostatic drugs are those drugs that are going to suppress the growth of the bacteria. So we have studied about the mechanism of action, different names of the drugs in this category. We have gone through the side effects and as well as uses. If I revise the names of the aminoglycosides, they do include gentamicin, amikacin, kanamycin, streptomycin, neomycin. All the mycins were aminoglycosides. When we move towards the name of the drugs that come in the category of macrolides, we said erythromycin and azithromycin, telithromycin, they are macrolides. So let's discuss today's topic, that is tuberculosis. Tuberculosis is actually the most important communicable disease in the world. And nowadays, corona is actually the most important communicable disease that is going all around. But same in the same way that corona is going to pass through the you can say the carrier state is through the nasal route or through the respiratory route. The droplets are going to be carried through the nasal route and respiratory route, and they affects the lungs. Similarly, tuberculosis is the one that is also a communicable disease that is also transmitted by the droplets that are coming from the carrier person, or that is going to affect the healthy person. Here I use the word that the tuberculosis bacteria may affect the healthy person, but actually there are different types of the categories of the person. Either the person is healthy or either the person is going to have less immunity. For example, if I'm a healthy individual and the bacteria are going to come to me and they are going to go in my body, and if my immunity is strong enough, then my immunity would be able to either degrade the bacteria, and the bacteria, mycobacterium tuberculosis, will be degraded. But if my macrophages that are going to kill the bacteria or degrade them are just going to take the bacteria and going to keep it in a dormant state, and if my immune system was not healthy enough that it may degrade it, instead of it may keep it in my body, then it is going to cause harm when my immunity is going to weaken any the time duration in my life. That dormant bacteria become activated and shows this effect. Fine. I revise these things again. Anyways, tuberculosis is a chronic granulomatous disease that leads to serious infections of lungs, genitourinary tract, skeleton, and meninges. The organism which is responsible for the tuberculosis is Mycobacteria tuberculi, is actually able to grow very slowly as difficult to culture and is treated for 6 months to 2 years. The management regime of the tuberculosis or antibacterial therapy for the tuberculosis is going to take a long time. It's not that you are going to take it just once a time and you are going to get rid of it in few days. Actually, it's a chronic granulomatous disease. When it appears, it shows its symptoms. When it becomes chronic, similarly, you take a much longer time to deal with this resistant type of the bacteria that has affected your respiratory system, and that bacteria is named as Mycobacterium tuberculi, and it was discovered by Robert Koch in 1982. After the spread of AIDS, the problem has become more complex because I earlier told you if the immunity is weak, this bacteria will be able to grow in that or multiply in that person and then it affects. So as the tuberculosis and Mycobacterium avium complex infections are more common and rapidly progressive in AIDS patients, those patients that has compromised immunity is going to show its effects more as compared to the healthy individual and the healthy one that is able to degrade the bacteria, or either there may be possibility that in even healthy individual the bacteria are going to invade in the macrophages and go towards a dormant state and they become activated whenever in my lifespan when my immunity is going to weaken down. Let's discuss the strategies for addressing the drug resistance by the Mycobacterium tuberculi. This bacteria that is going to cause the tuberculosis has different strains, and these strains are strong enough that they show resistance to particular agent that emerge during the treatment by using a single therapy. In simple terms, I'm saying that we can't use a single drug for the treatment of tuberculosis because the strains of Mycobacterium tuberculi are much able to show resistance towards a single drug. So we need to modify our plan. What we do is we use multi-drug therapy. We employ it while we are going to treat the tuberculosis. And this purpose of inducing or introducing multi-drug therapy is to delay or prevent the emergence of resistant strains of Mycobacterium tuberculi. So according to the clinical utility, the anti-tuberculous drugs are divided into two main categories according to their effect. Number one are first-line drugs, mean the first priority drugs that we are going to combine in tuberculosis, and other one are second-line drugs. First-line drugs have high anti-tubercular efficacy as well as they have a low toxicity that and therefore they are being used routinely. So let me tell you the name of the drugs that comes into the category of first-line drugs. Number one is isoniazid. That is one of the most familiar drug that is being used in tuberculosis. And the other one is rifampicin, and third one is pyrazinamide, the fourth one is ethambutol, and the fifth one is streptomycin. Let's revise the first category drugs. Number one is isoniazid, the other one is rifampicin, the third one is pyrazinamide, and the fourth one is ethambutol, and the fifth one is streptomycin. Isoniazid and rifampicin are well-known anti-tuberculous drugs. Similarly, pyrazinamide, ethambutol, streptomycin also gain importance in this multi-drug regime. Streptomycin basically aminoglycosides, and we have studied aminoglycoside in our last week's lectures. The second line drugs are low anti-tubercular drugs that have a low anti-tubercular efficacy, but they do have high toxicity. So we have categorized them in the second category. The drugs that are enumerated in this class are ethionamide. Number one is ethionamide. The other one is thioacetazone. The third one is para-amino acid. And the fifth one is cycloserine, amikacin, aminoglycoside, ciprofloxacin, fluoroquinolone, kanamycin, aminoglycoside, rifabutin, capromycin. So these all drugs are second-line drugs. I have categorized these drugs into two categories. Number one is first-line drugs, the other one is second-line drugs. First-line drugs are isoniazid, rifampicin, pyrazinamide, and ethambutol, and streptomycin. And second category or second-line drugs are ethionamide. Sorry, last one was, I'm going to revise it, isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Second-line drugs are ethionamide, thiacetazone, para-amino-salicylic acid, cycloserine, amikacin, kanamycin, capromycin, ciprofloxacin, and rifabutin. Fine. The next category or next division of the drugs is on the basis of the spectrum of activity. We have classified the anti-tuberculous drugs into different categories or depending upon the different headings. Like first classification was on the type or the choice of first priority drugs or second priority drugs, and this classification is on the basis of the tuberculous activity, anti-tubercular activity. And in this way, they are divided in two categories. Number one is tuberculosidal, the drugs that are going to kill the Mycobacterium tuberculi, and the other one is tuberculostatic, the drugs that are going to suppress the growth of tubercular bacilli are said to be tuberculostatic. Static, that suppress the growth of the Mycobacterium tuberculi. Sidamine, the one that suppress the growth of Mycobacterium tuberculi. So the drugs, if we categorize them on the basis of tuberculosidal and tuberculostatic, isoniazid, rifampicin, pyrazinamide, streptomycin, they are all tuberculosidal. And if we go through them in the details, we know isoniazid is as well as first line drugs, rifampicin is first line drugs, pyrazinamide is also first line drug, streptomycin is also first line drug. So all the first line drugs except ethambutol are tuberculosidal in action, while amikacin, ciprofloxacin, kanamycin, rifabutin, capromycin, they belong to second line category, but they are also tuberculosidal drugs. I said all the drugs that are from first line category except ethambutol are tuberculosidal. Other than that, amikacin, ciprofloxacin, kanamycin, rifabutin, capromycin, they are second line drugs. They are also tuberculosidal in action. The next is tuberculostatic. So ethambutol, which is from the first line category, and ethonamide, thioacetazone, paraminosalicylate acid, and cycloserine, they are second line drugs. Now we're moving towards detail of each drug, like what is the behavior of isoniazid, rifampicin, pyrazinamide, what are the possible side effects. Actually, in tuberculosis, we are going to combine different drugs and going to combine and give a multi-drug type medication. And in this we have categorized or added up 3-4 drugs together and going to give a patient a number of the drugs at a time. Obviously, the purpose of giving these number of the drugs together is we want to overcome the resistance that is actually shown by the Mycobacterium tuberculi. For this purpose, we are going to give 3 or 4 types of drugs together in order to overcome the resistance that has been shown by the Mycobacterium tuberculi. But every drug has some side effects, and we have to face these side effects along by along. And we have studied about this, that there are certain drugs that are going to show you other side effects, that even you're going to give them for a certain purpose, but instead of only treating that cause, they are also inducing some other diseases, like we say drug induced or physician induced like effects. So moving towards the first anti-tubercular drug that do have certain actions, but it also has side effects. So we have to keep in mind the side effects of every drug, so that if a patient complains to us that I am facing this issue, so you may guide your patient that it is actually due to this effect, and this is pre-decided, you have to face it, and now by using certain other medication we are going to treat them. The first line anti-tubercular drug is isoniazid. It is the most effective and the most cheapest drug. Therefore, we are going to prefer them in the isoniazid, that the person has to use it for a long duration, and due to its property that it is a cheaper drug, we can use it effectively. The next are few other properties of isoniazid, that it is effective against both intra as well as extracellular mycobacterium. It is effective for those bacteria that has invaded the cells or that is present extracellularly. It is going to kill them. Meanwhile, it is also going to act as bacteriostatic against resting organism, while it is going to act as a bactericidal against rapidly multiplying organism. I'm again going to revise in simple. We said it is a cidal, but it is going to act as cidal for those bacteria that are going to multiply. It acts cidal, but even those bacteria which are resting, it is going to suppress their growth and going to ultimately deprive them from their capability, and this way it is going to overcome the Mycobacterium tuberculi bacteria. Next is about the mechanism of action. Every drug has a mechanism of action. It's very important to understand the what is the mechanism of action and how they are going to and what they are going to do in a certain condition and how they are going to kill or suppress the growth of the bacteria. And here, Mycobacterium tuberculosis. Isoniazid is actually going to inhibit the synthesis of mycolic acid. The point is, what is this mycolic acid? Mycolic acid is actually one of the very important component of mycobacterium cell wall, as like peptidoglycan, which is a very important component from the gram-positive organism cell wall. Here, there is a mycolic acid, which is very important component for the Mycobacterium tuberculosis. And if we inhibit its synthesis, we are going to weaken up its cell wall. In this way, we will be able to uh, make it disable to survive, and the bacteria is ultimately going to be lysed and going to be killed. The next are adverse effects of isoniazid. These adverse effects are usually not representable in low doses, but if the person is going to use it in higher doses or depending upon the requirement, these effects may appear. What are they? Number one is hepatitis, inflammation of the liver which may result even in the loss of appetite, nausea, vomiting, and it may even cause jaundice. The other very important adverse effect of isoniazid is peripheral neuropathy. And this peripheral neuropathy is just because of deficiency of pyridoxine, which is vitamin B6 in the body. Actually, due to use of isoniazid, the utilization and excretion of vitamin B6 is actually going to be promoted, due to which there is decreased amount of vitamin B6, and which is going to give you peripheral neuropathy. So what we can do is, in order to prevent this peripheral neuropathy, we may use pyridoxine supplements as alternative to manage this one. So rapidly it is reversed by administration of pyridoxine. There are other side effects like central nervous toxicity, less common, and actually it's less common, but it may cause memory loss, psychosis, and seizures. I'm going to revise the divorce effects. Let's revise it with me. Hepatitis, which may cause loss of the appetite, nausea, vomiting, and GI side effect. It also causes peripheral neuropathy, which is also another important divorce effect of the isoniazid. With the predisposing condition, it is going to enhance, like with patients of malnourishment, alcoholism, and diabetes, and AIDS, and uremia. This peripheral neuropathy has a more risk factor to be in them. So it may be readily reversed by the administration of pyridoxine, mean vitamin B6. Central nervous toxicity, which is less common, it includes the memory loss, psychosis, and seizures. Moving towards another picture that is related to isoniazid side. Number one side effect of isoniazid is here in this picture, which is being clear, that related to the CNS, that is memory loss, hallucination, epileptic type side effect. Further than that, we said it is going to cause hepatitis, it is going to cause peripheral neuropathy. Along with this, it may cause gynecomastia, anemia, hallucination, and arthritis. These are associated side effects of isoniazid. So moving towards the next category that we have is rifampicin. And before that, rifampicin, this is a picture to show you that the metabolites of isoniazid appear in the urine. Isoniazid is also an enzyme inhibitor. This is also important, and for MCQs purposes, it is important to keep in mind that isoniazid potentiate the adverse effect of phenolphthalein just because it's an enzyme inhibitor. Let's discuss something about rifampicin. Let me tell you, this one is again tuberculosis for Mycobacterium tuberculosis. It rapidly penetrates most tissues and penetrates even in the phagocytic tissues. Another important thing about this is it acts as a persister. Those like bacteria that are in dormant state, that are going to act as dormant. This one is rifampicin is also able to kill them even in that state. Although other anti-tubercular drugs are not able to kill this persistent form of the Mycobacterium tuberculosis. But the issue is we can't use it alone because the resistance would be developed, so we have to use it in combination therapy. Let's discuss something about the mechanism of action. The mechanism of action of the rifampicin is to bind to the bacterial DNA-dependent RNA polymerase, and by binding to this one, it is going to inhibit the RNA synthesis. So it is the one that is going to inhibit the RNA synthesis of the bacteria. The other important thing about rifampicin is it is an enzyme inducer, meaning it is going to enhance the number of the enzymes, so it is going to increase the metabolism of different drugs. Moving towards the adverse effect of rifampicin, they are very interesting that they are going to give us a one of the first harmful effect, that is harmless orange yellow coloration of the urination, sweat and tears. Patient usually comes to the doctor and says that nowadays I am noticing that my coloration of the urine is somehow orange or yellow. So you may guide your patient, is not nothing to be worried, it's just because of you are going to take rifampicin, which is going to give you orange yellow appearance in the urine. Occasionally, the patient have seen the certain other adverse effects like rashes, nephritis, hepatitis, light chain proteinuria, flu-like syndrome is also noticed in patients like fever, chills, myalgias, and anemia type symptoms. And the risk of hepatitis is greater in the individual who are alcohol dependent, or possibly during the pregnancy or in the postpartum period. These are overall uses of rifampicin. In this topic, we are just saying rifampicin is good for tuberculosis. Other than this, it is being used in other atypical mycobacterial infections like in leprosy, has been used in prophylaxis of H influenza. It also eliminates the meningococcal carrier state, and is being preferred in brucellosis along with the doxycycline. It's considered to be drug of choice with doxycycline. The third drug we have is ethambutol. Ethambutol is a one first-line drug that is actually by nature bacteriostatic. So it acts more on fast multiplying bacteria and that have invaded the cavities. It's even effective against Mycobacterium avium complex infection. Although there would be a development of resistance if we are going to use ethambutol alone, so we have to give the ethambutol in combination with other or any other antitubercular drug like isoniazid. Moving towards the mechanism of action of ethambutol, let me tell you how it is going to affect the bacteria. It's going to affect exactly like the first drug that we have studied is isoniazid. It inhibits the mycobacterial cell wall, and how it do is it inhibits the incorporation of mycolic acid, and this way it is going to like weak the cell wall of the Mycobacterium tuberculi, due to which it would not be able to be in a survival state and get lyzed. The next we have are the adverse effect of ethambutols. Ethambutol is going to give us other number of the adverse effects like optic neuritis, loss of visual acuity, red and green color blindness. This is another different type of side effects that you have to keep in mind, that this is by the use of ethambutol. What it is, red, green color blindness. Along with this, there is nausea, vomiting, anorexia, headache, fever, and allergic reactions. Let's revise it again. This one is going to give us optic neuritis. It is going to give us loss of visual acuity, and red and green color blindness means you are not able to differentiate between red and green color. The next one is pyrazinamide. Pyrazinamide is a tuberculosidal like isoniazid. It's a more active against acidic pH. It's effective against intercellular organisms, and it is highly useful in meningeal tuberculosis. These are the adverse of pyrazinamide. The one of the most common one is hepatotoxicity. Other than this is hyperuricemia or arthralgia. Hyperuricemia means higher levels of the uric acid in the blood, and arthralgia means joint ache or joint pains. Nausea, anorexia, vomiting, fever, rashes are the side effects that are associated with that drug, pyrazinamide, and pyrazinamide is a first-line drug. It is safer in the pregnancy, but it is not safe in the liver patient because it causes hepatotoxicity. The next drug is streptomycin. As we know, this one is aminoglycoside, and we are actually we have the fresh knowledge about streptomycin, that how it is going to work, what is the mechanism of action, what are the possible side effects. So just to move towards the review of this, one point is the first clinically useful antitubercular. That this is one of the additional benefit of this is that it was the first drug that was actually being used for antituberculous therapy, but it is less effective than isoniazid. When we have discovered isoniazid or rifampicin, we found that they are even more good than the streptomycin. Although it is also bactericidal and it inhibits the bacterial protein synthesis by binding the 30th ribosomal unit, and it inhibits the reading of genetic coding and causes the inhibition of the protein synthesis. It acts on the extracellular bacilli and has a poor penetration into cells, and it is injected intramuscularly. But the point is that it is not able to cross the blood-brain barrier, so this one is not effective on the meningeal tuberculosis. It is not being, it can be used initially for 1 or 2 months in pregnancy, but overall it is not being preferred in pregnancy because it do affect in the next period of the pregnancy. But we know streptomycin is autotoxic and nephrotoxic, and neuromuscular effects are also related to these that are offered by the streptomycin. And we said, along with streptomycin, we are not going to use other drugs that are autotoxic like diuretics, and we are also not going to use other nephrotoxic drugs like cephalosporins and cisplatin. We are also not going to use these skeletal muscle relaxants along with streptomycin because it causes neuromuscular paralysis. And skeletal muscle will enhance the paralysis. In this way, we are going to avoid the combination use of these drugs with aminoglycosides. The next is second-line antitubercular drugs. There is a long list of second-line antitubercular drugs. They are actually good, but they have more side effects than first-line drugs, so they are going to come after its first-line drug category. So these are the drugs that are considered only when the resistance to first-line drug has developed, and there will be failure of clinical response to the conventional therapy. And then we are going to move towards the second-line antitubercular drug and serious treatment limiting adverse drug interactions. Number one is thioacetazone. Thioacetazone is tuberculostatic in nature, meaning the drugs that is going to suppress the growth of the bacteria. It has low efficacy, as this is also going to give a number of side effects like hepatotoxicity, dermatitis, allergic reactions, and gastrointestinal side effects like nausea, vomiting, and diarrhea type effects. The next we have is thionamide, is bacteriostatic, meaning the one that is going to suppress the growth of the bacteria. It is effective against both intra and extracellular organisms, and it is also effective against atypical mycobacterium. But it offers some adverse effect like anorexia, nausea, vomiting. But the different type side effect is metallic taste, which is very common with these type of thionamide antitubercular drug. It also causes hepatitis, skin rashes, and peripheral neuropathies. You have to keep in mind all the diverse effect all these drugs individually. The next is para-aminosalicylic acid. Para-aminosalicylic acid is related to sulfonamide, and it is considered to be bacteriostatic. It has a it is highly specific for Mycobacterium tuberculosis, but not effective against other Mycobacterium species. So it is being used limited for the treatment of multi-drug resistance tuberculosis. We discourage its use just because of the primary resistance, or poor compliance due to GI intolerance, hepatitis, and allergic reaction that has been offered by the use of para-aminosalicylic acid. The next we have is amikacin, kanamycin, capramycin. They are all categorized in a single heading as they're all aminoglycosides. So they are going to be used parenterally, and we know they have side effects, autotoxicity, nephrotoxicity, skeletal muscle relaxants. So we are going to avoid to use with other drugs that are going to offer the same type of side effects. They are used in resistance cases only when we are going to get failure by the first-line antitubercular drugs. The next we have is cycloserine. It is also a second-line drug. It inhibits the cell wall synthesis and it acts as a tuberculostatic. It is being used in the resistant cases, and it is highly effective against gram-positive organism. It causes CNS toxicity only. So this is a reverse vaccine with the cycloserine. The next is about fluoroquinolones. They are useful in multi-drug resistance genes as they inhibit the tubercular bacilli benefiting the DNA polymerase enzyme. And this one is about the fluoroquinolones like ciprofloxacin that is here in this category. Ciprofloxacin also offers a number of the side effects that were listed in the topic of fluoroquinolones. Moving towards the treatment of tuberculosis. Because of the poor patient compliance and other factors, the number of the multi-drug resistance organism has risen. Although the treatment regime vary in the duration and the agent that employed, and the way they always induce a minimum of usage of two or more than two drugs, preferably with both being bactericidal in properties. As we earlier said, these drugs, these strains or Mycobacterium tuberculi is not able to be controlled by single drug. So we are going to combine it even in combination more than two drugs, and the both of them should be of equal nature, like at least they should be bactericidal. But patients show poor compliance just because it's very like difficult for the patient to take it for a long duration, and it is going to give you nausea, vomiting, and you have to take it for 2, 3, 4 months. The patient usually feel uncomfortable for taking daily basis dosage regime, and so they try to avoid it and go out of it, and this way there is actually poor control over the Mycobacterium tuberculi. The short course for the chemotherapy of tuberculosis includes 2 month treatment by initially isoniazid, rifampicin, pyrazinamide, and ethambutol, and this is considered to be intensive phase. And other one is for next 4 months, in which the patient has to take isoniazid and rifampicin. This one is considered to be the continuation phase. The next is the conventional regime that were previously being used. That was actually isoniazid, streptomycin, and thiazidazone for 2 months. And for the next 10 months, there was isoniazid and thiazidazone that was being preferred. And this 12-month duration was so long that the patient feel uncomfortable along with so many side effects. So they usually try to get out of this plan and these try to survive without it, and in this way their tuberculosis is going to further develop and multiply and going to affect the respiratory system even more, and the failure rates are considered to be high and the compliance is considered to be poor. Sometimes the treatment continues for 1 year even after the sputum becomes negative. It's not necessary that when you are going to get from test for the tuberculosis and sputum test is going to give you like negative, it is going to show you it's all is over. But still, they might be present. Might be possible that bacteria is present in the dormant state. It do come back. So you have to complete the regime until unless it's been assured that all dormant stages have also been eradicated from the body. You have to complete it more than that duration so that at least you're going to kill the persistent stage of the Mycobacterium tuberculosis. The next is another therapy that is named at by the therapy regime DOT. That is, the DOT is directly observed therapy. I earlier told you this is uncomfortable for the patient to take this medicine, so they skip their medicine, or like for example they have to take it twice a day, they skip it 1 day or 2 day. In this way the Mycobacterium tuberculosis begin to multiply again. So this strategy, this directly observed therapy, was actually planned for the good compliance of the patient, and one successful strategy for achieving a better treatment completion rates, in which the patients take their medication while being supervised and observed. DOT has shown to decrease the drug resistance as well as relapse and mortality rates to improve the cure rates. And most local and state health departments offer these two services in their domains. These are the drugs that are listed for the Mycobacterium avium complex. This is also very common in HIV patients. Clarithromycin and ethambutol are preferred regime for MAC infections. Rifabutin is used for prophylaxis, and other drugs that can be possibly used are azithromycin, clozamine, amikacin, ethanamide, and fluoroquinolones that can be used in this case. So this was something about anti-tuberculosis drugs, in which we have studied about first line drugs, and we have also discussed about second line drugs. We said first line drugs are isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. Almost all the first line drugs except ethambutol are bactericidal in action, mean tuberculocidal in action. All the other drugs are bacteriostatic, mean ethambutol is bacteriostatic in nature. We've also studied about the mechanism of action of isoniazid, where we said isoniazid is the one that is going to suppress the growth of the mycolic acid, and mycolic acid is one of the very important component of bacterial cell wall, mean mycobacterium cell wall. And in this way, you're going to hinder the survival of the Mycobacterium tuberculosis. Other additional closing point here, it is we said we are not going to use one drug at a single time. We need to use multi-drug regime in order to overcome the resistance shown by the bacteria. Along with this, we said there are a number of the side effects that has been offered by the different drugs. That like isoniazid is going to give us peripheral neuropathy, and hepatitis and CNS related side effects. Similarly, the rifampicin is going to give us hepatotoxic hepatitis, along with orange yellow discoloration of the urine and flu-like syndrome. There was another drug that was going to give us red green color blindness. So you have to keep in mind that there are different side effects of every drug, and we have to enumerate the adverse effect on a single table to keep in mind that what else would be the possible adverse effect by this type of drug and this type of drug, along with the mechanism of action and the spectrum of activity. With this, I am going to close up today's session, and inshallah, in the next session, I am going to continue with the next topic that is related to anti-amoeboids or anti-amoebotic drugs. So till then, Allah Hafiz, I'm going to post up this lecture in the Google Classroom. Kindly go through this, and we will have an interactive session and quiz type activity in our next interactive class. Allah Hafiz.